Okay, here we go. Ding, 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 and a 1, a 2, a 1, 2.
Thank you for joining us, Dr. David Fiorella. What you do is highly specialized, and by all accounts, you're a trailblazer in your field, and so it appears to me more than just about being a doctor for you. Why don't we start by having you talk about what prompted you to pursue a medical career, more specifically, your mission with respect to vascular diseases of the brain, strokes, aneurysms. What brought you there?
Yeah, I'll start out just by explaining what I do, because I think for a lot of people, this is something it's a little bit foreign to them. Back years ago, really the only way to access the brain, the blood vessels of the brain, was to do open brain surgery. So you'd put a patient under general anesthetic, make an incision in their scalp, and remove a piece of skull to get at the brain. And as you could imagine, it's a pretty involved procedure. It turns out that a lot of the procedures that are now done on the blood vessels of the brain are actually able to be done through the inside of the blood vessels, so through an endovascular technique. So similar to cardiac surgery that, again, back at one time was all done with open cardiac bypass, where they'd open up your chest and work on your heart directly. A lot of those procedures were converted to procedures that were done through the inside of the blood vessels. So coronary stents replaced a lot of coronary bypass surgery, and that's how that field went. Well, neurosurgery, neuro-endovascular procedures have really proceeded in much the same way. So a lot of the diseases of the brain blood vessels that used to require open surgery now can be done minimally invasively through the inside of the blood vessels. And so it's a very new, technologically driven field. The senior guys in our space, in our field, a lot of them are my age, so it's something where getting involved with it at the time that I did, it was a very rapidly moving, technology-driven, innovation-based field. And it's really allows you to do miraculous things on a daily basis. And what we're going to talk about today, the treatment of the interventional stroke care, treatment of stroke with interventional endovascular techniques, is really something where you treat a common disease. So it's a process, a disease, a procedure that we do a few times a week, treat that. And it's really the opportunity to perform a miracle on somebody medically a couple of times a week, which is unique to, I think, almost any field of medicine. So you have a patient who comes in with a blockage of a blood vessel going to a portion of the brain. That area of the brain's not getting blood or oxygen. And so the way that your brain responds to that physiologically is it just shuts down. It stops working. So you have a patient who the left half of their brain stops working. So what does that look like? They're paralyzed on the right side of their body. They can't move or feel the right side of their body. They can't speak or understand speech. So really, everything that you are as a person, your ability to speak or understand language, that goes away, and you're paralyzed on the dominant side of your body. Over time, if that blood vessel is not opened up, those brain cells not only stop functioning, but they start dying. And when brain cells die, they're lost forever.
Can't be replaced.
Irreversible, yeah. So you don't regenerate brain cells like you regenerate liver cells. So the idea is if you can go in and remove that obstruction, remove that blood clot, and restore blood flow to that side of the brain, that brain will come back to life almost instantaneously. And so what that looks like clinically to me is I see a patient in the emergency room, they're brought in, they're paralyzed, they can't talk, they can't understand speech, they have a process that has a high level of mortality and extraordinary morbidity if not treated. We go in through the inside of their blood vessels in a procedure that sometimes can just take 15 minutes. We can actually physically grab the clot with our catheters or other devices and pull it out of the head and remove it. And within 5 minutes, that same patient can move on the right side and start talking again.
So, I mean, it's fascinating. Within the limits of confidentiality, obviously, is there a particular case that stands out for you so far that, inspires you to this day along these lines?
Yeah, so it's an interesting question. And all the cases are like what I described.
Right. So they're dramatic. They're vivid.
They're dramatic, and the sort of the ability to do this, it's such a privilege to be able to practice in this space of medicine at this time that I would say that it's really not one individual case you think about, because there are 2 or 3 of these from last week that we had. Yesterday we had a patient who came in with an NIH stroke scale 25 with the exact same exam I described to you, a person who was perfectly functioning, going about their normal lives, and a clot traveled from their heart to the left middle cerebral artery, the artery that supplies the left side of the brain. And all of a sudden,
shut them down.
She's paralyzed and she can't talk. And she's brought into the cath lab immediately. We go up and we pull the clot out. And within 15 minutes, she's talking again. She's moving the right side of her body. And likely she'll be discharged home with no services. So this is somebody who, if they are not brought to Stony Brook and they don't get your procedure, they either will not survive that or they'll be severely impaired for the remainder of their lives. and within a couple of minutes, you can do a procedure and they're normal afterwards.
Right. So, I mean, a very important part of this remarkable practice of yours are these so-called mobile stroke units. So maybe you can tell us a little bit how that fits into this scenario you're sharing with us.
When you have a blocked blood vessel to a portion of the brain, as you'd imagine, as we talked about, that brain stops functioning. And they're stopping functioning because it's trying to preserve all of the oxygen and glucose it has to maintain its viability. So it's trying to hang on to life. And it only can do that for anywhere between 15 minutes to an hour at best, because collateral circulation gives it a little bit of blood supply so that it can continue on for some time. So every minute you're losing neurons. Neurons are irreversibly dying. So the sooner that you can get those blood vessels open, the better it is. The way that emergency medical services have been structured for the past couple of decades were to deliver patients to a hospital where they could get intravenous TPa. So TPa is a clot-busting medication. They give it through the veins. It floats throughout the entire body, and the idea is it sometimes can dissolve up these clots. Unfortunately, for these large vessel occlusions, for the big clots, the kind of clots that we pull out that create these severe strokes, like the stroke I described to you, TPA doesn't work very well in those cases. It only works about 20-25% of the time for patients who have intracranial occlusions. So TPA fails most of the patients who it's delivered to. And you could imagine if you're going to give a medicine in the intravenous, it's going to go where there's blood flow, but we need it to go where there's not blood flow. And so that's why it's not all the time effective. And in fact, it's only effective a minority of the time. So emergency medical services is still structured in a manner where they are mandated by law to bring patients with strokes to the nearest hospital that can deliver them TPA. So unfortunately, if that's a smaller hospital, they don't have the interventional capacity that Stony Brook has. So Stony Brook is really the only academic center in the area that's a comprehensive stroke center that can deliver these services 24 hours a day, 7 days a week. If that patient is brought to a smaller hospital and they stay at the smaller hospital, usually the average door in, door out time for a major stroke at a primary stroke center that doesn't do endovascular services is in the neighborhood of 2.5 hours. So it takes about 2.5 hours to figure out that patient's having a stroke at one of these smaller hospitals, to identify that it's a stroke from a large vessel occlusion, and to get that patient out the door to a place that can treat them. That 2.5 hours lost is a significant amount of dead brain. And so prior to the mobile stroke units, many of the patients that we would get at Stony Brook were transferred from other hospitals. By the time they got to us, even if we could do a successful revascularization, and our rate of getting the blood vessels open at Stony Brook is 95% or above. So almost everybody that we get at Stony Brook, we can open up that blood vessel. The idea is, did we get that blood vessel open in time enough to preserve their brain? And so the mobile stroke unit really helps this in tremendous ways for these patients. So the way the mobile stroke unit works is it's an ambulance, but it's specially equipped. So it's an ambulance with a CAT scanner. So it's got the CAT scan built into the ambulance. It's staffed by an EMT, a paramedic, a critical care nurse, and a CT tech. So you have a stroke at your place of work or at your home, you call EMS and say, my loved one or my relative's having a stroke. So the typical ambulance responds along with our mobile stroke unit. And if the mobile stroke unit staff and the ambulance staff go in and assess the patient, say, yes, this does look like somebody who's having a stroke, that patient goes directly into the mobile stroke unit. Our neurologists at Stony Brook can see the patient and do a quick exam, so they can exam by a qualified stroke neurologist, just as though they were at Stony Brook.
Right.
If it does look like they're having a stroke, they go right into the ambulance, and the ambulance can perform a CAT scan, and that can say, does this patient have bleeding in the brain, where we'd want to give them an agent that would thicken up their blood and reduce their blood pressure, or does this patient have a normal-looking CAT scan and a blocked artery to the brain, at which case we can give them the IV medication to try to lyse up the clot, bring them directly to Stony Brook, meet them at the door of Stony Brook, and bring them right into the cath lab for intervention. If the patient doesn't have a hemorrhage and is not having an ischemic stroke, then that patient can go to the local hospital to take care of them for whatever their issue is that's creating the medical problem at the time. So what that does is it allows patients to be transferred to the most appropriate hospital for their care the first time, and we know what their diagnosis is. So rather than coming to Stony Brook, having to be evaluated by our ER doctors and neurologists, then go to a CAT scanner to get a CAT scan and a workup, it's all done. Right. So we know that patient has a large vessel occlusion. They don't go to the ER. They skip right through the ER, go right into the OR, and we go in and we take the clot out.
Interesting issue here, though. So somebody makes an emergency call, says, something's wrong with my loved one or my housemate or my coworker. They don't necessarily know it's a stroke, right? These are not medical professionals. So I assume there's some interaction going on in that phone call where a decision is made whether to deploy the stroke unit or just your, quote, general run-of-the-mill ambulance?
Absolutely, yeah. So but the regular ambulance is always deployed to the scene. And so our sort of standpoint from the Stony Brook system is, if you think there's any chance this could be a stroke, invite us
Send the
along.
unit.
We'll come in. The unit comes in. If we evaluate the patient, it doesn't look anything like they're having a stroke. And in fact, that's the case the majority of the time that we respond. Our unit goes back into service and the local ambulance takes care of that patient. A lot of times our unit's going back into service, immediately going to another call. And so we attend a fair number of calls, probably 2 calls for every 1 call that's an actual stroke. But for those actual stroke patients, this is just a revolutionary advance for them. So
How many units currently deployed?
we have 2 units deployed, and we're hoping to get a 3rd one sometime soon. If we're able to get a 3rd one, then most of Suffolk County could be covered by mobile stroke unit care.
And is Stony Brook the first academic medical center to deploy units like these?
No, there are several units, and this concept has been around for almost a decade now. So it started out in Germany, and then it was brought over to the United States. The first 2 units in the United States were deployed in Houston and the Cleveland Clinic in Cleveland, and this was maybe like 6-7 years ago. There are a couple of programs up and going now. It's still a very new concept. We're very much early adopters, and our model of mobile stroke unit care is different from what it is at many places in the country. We have a unique geography that particularly lends itself to the mobile stroke unit care.
Meaning the dispersion of population on the eastern end of Long Island?
Yeah, that's exactly right. So if you think about Suffolk County, it's like I think of it as like the world's biggest suburb. And so you have one big academic medical center, Stony Brook, that's a comprehensive stroke center, and multiple other centers that are smaller hospitals that are good primary stroke centers and good local community hospitals. And so if a patient has a stroke, the most likely thing in the past is they would go to one of these community hospitals. And unfortunately, again, the time that it took them to recognize the stroke and to transfer them to us cost those patients hours. To be able to take patients and directly transfer them to Stony Brook is a huge advantage. So most of the places that have these mobile stroke units, they are based at the hospital and they go out to calls in the community, typically around the catchment area of that hospital in the more suburban areas where these ambulances tend to be. In our geography, we have them stationed on the LAE, so at exit 57 and 68, where they are close to north-south arteries along the east-west corridor that the LAE is. And then the next one would be out at the east end by the Forks. And so what that allows us to do is deploy within a 10-mile radius. We can cover a huge population. And for those patients that need advanced tertiary level care, so either a thrombectomy, the interventional procedure for removing clots, or they have a big blood clot in their brain, those patients, they're bleeding in their brain, those patients need to come to Stony Brook emergently. Those patients were always going to end up at Stony Brook, but they were going to stop off at another hospital for a couple of hours.
And that waste of time no longer occurs. They're going to come straight on.
That's the idea. So now if we can get 95% of the arteries open for patients who come to us, that's 95% of the people that potentially could walk out of the hospital.
It's also interesting to hear you talk about Suffolk County and the eastern end of Long Island geographically, but also demographically. I mean, we have an aging population, so I assume deploying these units and this kind of interventional work is very important for our population on the eastern end of the island.
Yeah, especially so because we do have a fairly aging population. They're very healthy because people here have good health care and they are meticulously take care of their health a lot of times out here compared to places like in the southeast where obesity is more rampant and there's a lot more smoking.
So this extraordinary service has been operating since, I guess, April of last year. So you have a rough estimate of how many lives you have saved, have affected so far?
Yeah, so it's been on almost 1,000 calls, the 2 units at this point. So they responded over and over and over again to many different calls. And even for the patients who don't come to Stony Brook, they're going to go to whatever hospital they go to. They're going to have a full neurological consultation from one of our neurologists. They're going to have radiologic imaging, CT, CTA, read out by one of our neuroradiologists with reports. So they arrive at this outside hospital with a care plan and a diagnosis already. So that improves those patients. And we don't really track all those patients who don't come to Stony Brook. There's been almost 40 patients who've had thrombectomies coming to Stony Brook directly from the mobile stroke unit. Many of those patients would have gone to other hospitals and been there. They've come directly to us. And we've already gotten the first outcomes data on these patients when they've come to Stony Brook. It looks like the mortality rate for patients who have come from the mobile stroke unit compared to patients who had arrived previous to the existence of the mobile stroke units has declined from large vessel occlusion stroke from something like 25% down to 9% with the mobile stroke unit. So just a tremendous reduction in the mortality from stroke. And then we've seen the good outcomes at 90 days. So being able to be independent 90 days after a large vessel occlusion, that rate has doubled for patients who are brought to us on the mobile stroke unit. So your chance of dying from the limited data that we have the first 23 patients have a 3-month follow-up, 90-day follow-up. For those patients, the risk of dying was about 1/3 of prior to the mobile stroke unit, and the risk of having a good outcome, an independent outcome at 90 days is double. So your chances of doing well with a stroke, if the mobile stroke unit picks you up and brings you directly to Stony Brook, is really outstanding.
Can you share with us at all some of the comments you've received from families and patients? I'm sure there's been a lot of interesting interactions with, these individuals.
Yeah, so from the patient standpoint, once they hear about the program, especially if they've experienced it or somebody in their family's experienced it, they're absolutely evangelists for this program. And so we've had patients who are visiting here, or they snowbird down in Florida, and they go back to their communities in Florida over the wintertime, and they're advocating from their local communities to try to get a mobile stroke unit at their nearest hospital there. It's so intuitively obvious why this is good medicine and how this improves patient care that from any level, you don't have to be a medical professional to understand that time is brain, and that these types of units absolutely save time and absolutely save brain, and that translates to better outcomes and reduced morbidity from stroke.
Right. Let me ask you a couple of questions about you. Did you always know that this was the kind of work in medicine you were going to do when you made the decision to go to medical school, or did that evolve over time?
Yeah, so I went to medical school in Buffalo, in SUNY Buffalo. And at SUNY Buffalo, there was a neurosurgeon there named Nick Hopkins, who was one of the very, very first people to ever think about using catheters up in the brain to treat things like large vessel occlusion stroke. In the past, the outcomes of these patients, as you could imagine, were horrible when we couldn't get these big clots, when all we had was TPa. Most patients who had one of these types of strokes either died of it or were severely disabled. So as a medical student, Dr. Hopkins occasionally used to attend the neurology conferences and present his cases. And so he was trained as a neurosurgeon. He was actually trained by the cardiologist in Buffalo how to use the catheters and how to do these procedures. And he presented, when I was a medical student, a case of a basilar occlusion in a young patient. So the basilar artery supplies the back part of the brain. The back part of the brain is really all the wiring that takes everything that's going on in the higher part of the brain down to the body. So if you lose the back part of your brain, you're completely paralyzed on both sides. You can't talk or interact with anything, but you're wide awake. So you get the syndrome that's called the locked-in syndrome. It's one of the most feared things in all of neurology, the worst outcome for stroke. You can imagine being completely awake, but unable to move anything in your entire body. So he had a young patient who presented with this. He was able to go up with a balloon-mounted stent catheter and actually deploy a cardiology balloon in the patient's basilar artery and clear that occlusion that way. We don't do stuff like that today, but using the tools that he had at the time, and the patient went from being locked in to being neurologically normal. And he presented that case at this conference, and I thought to myself, if there's any way I could get into a field where this was what's going on, like if this is possible, this is really a spectacular thing to be able to do. And that at that time, that case was like a spectacular thing to see as a medical student, and even as a doctor in neurology, anywhere in the country, anywhere in the world, to see a case like that. That case has gone from being an oddity and a case reportable phenomenon to something that we're able to do every single day, that we have level 1A evidence. There are now 9 randomized controlled trials showing that thrombectomy is superior to the intravenous TPA. So it's the highest level of clinical evidence backing up what you do for a common disease process that you can treat every single day at an academic medical center where we've helped develop a lot of these technologies. We've participated in a lot of these trials. We have expertise doing it here. The success rate is enormously high, and it's just such a rewarding thing to be involved with.
So that brings me to another question I wanted to ask you. I know you've trained at a variety of very fine institutions. What attracted you to Stony Brook? Why did you come here?
Yeah, so Stony Brook was a really unique opportunity that's been given to me by the university, by the administration of the university, by the Department of Neurosurgery here, and I just can't speak highly enough about Stony Brook as an institution. So Stony Brook was out in Long Island in Suffolk County, referring all of their patients with cerebrovascular disease like this, emergent cerebrovascular disease, many of them into the city for treatment. There was no stroke center or stroke capability really here at Stony Brook. They didn't have a cerebrovascular center. So being at the Cleveland Clinic, being at the Barrow Neurological Institute, these were places that were established neurosurgical centers, huge academic medical centers that decided to start up a cerebrovascular program when it became a field, and they were building it on to a pre-existing area. So Cleveland Clinic, you could imagine, has many resource allocation demands from cardiothoracic surgery, every place, and you're sort of building on a cerebrovascular program into an existing radiology neurosurgery department. Stony Brook was a totally unique opportunity because it was a hospital that said, we want to start a cerebrovascular program from scratch, and we want to give you everything you need to do this the right way. So the infrastructure you need, the staff that you need, the support that you need, just take everything that you've seen at the Cleveland Clinic that was good, everything you've seen at the Barrow that was good. We want to take the best parts of all of these different experiences that you've had and build them into what you think would be the optimal center. And so I think we've built the absolute optimal cerebrovascular center here from Stony Brook because we were able to start from zero.
And it's marvelous. And listening to you earlier, time is brain. So you've provided an extraordinary service to the people at the eastern end of the island, given what the treatment patterns were in the past, given the travel they had to.
Yeah, it's you could imagine if everybody in Suffolk County who was having a acute ischemic stroke from a large vessel occlusion had to go into Nassau County or the city to be treated. And the other capabilities here, a lot of the work for the elective treatment of cerebrovascular disease, so say brain aneurysms, many of the new devices for brain aneurysm treatment, we were one of the first or the first people in the world to do or participate in. Many of the larger trials for the approval of devices that we use to treat brain aneurysms, we've not only participated here in Stony Brook, but I've been able to be the national PI for these trials. So the trials that are actually done on the new devices to present to the FDA to ultimately get approval, a lot of that work we've been able to do here at Stony Brook. And it's really a testament to the administration here, to the Department of Neurosurgery, because they've been so forward thinking to make the investment and just so incredibly supportive. I've many colleagues, as you can imagine, it's a fairly small field at many different hospitals, and I hear people constantly complaining about their hospital administration, not getting enough support, not having enough research nurse support, not having enough infrastructural support. And I just can't say enough about Stony Brook and their willingness to make investments when the investments make sense. So for the mobile stroke units, these units cost over $1 million each. They cost $1 million a year to staff. And there is a return on that investment, but much of the return on that investment is through good patient care. So patients have earlier discharges from the hospital. They're discharged in better condition to better dispositions. There's lower mortality rates. And through reducing length of stay, ultimately in the long game, you are going to see these create a situation where they're not losing a ton of money for the university. But at the same time, it's a very, very big upfront investment and a leap of faith to make based on we want to practice good medicine, and by practicing good medicine, that's how we're going to be successful. And it's very rare that an administration actually approaches things in that manner. And Stony Brook is unique in that regard because, again, many of my colleagues spend a lot of their time
different universe
going up to the administration trying to get these things. And here, they're just so good about seeing this is good medicine and this makes sense and we need to do this.
That's right. One final question I always enjoy asking my guests. What would you tell David Fiorella, the high school student or the college student, today if he asked you for your advice?
Yeah, what I would say is you stay on the path. Like I just can't tell you what a rewarding field medicine is and what a rewarding field this form of medicine is. There's not a single day that I don't wake up in the morning and I'm happy to get in my car to drive to work. When my pager goes off in the middle of the night, I'm happy to have my pager go off to get called in to do a case because we're doing exciting things, helping patients. And in the middle of the cases and the procedures that we're doing, I look around at the techs and nurses who are working with me, and we are all thinking the same thing, like where would we rather be than doing this right now? It's just absolutely such a privilege to be practicing in this field at this time as things are moving fast forward in such a way. What I tell the patients is it's like every 6 months in this field, we learn something new, we can treat something new, we get a new device that allows us to do something that 6 months ago we'd never thought would have been possible. And the privilege to be able to practice in a field of medicine like that at this time is really just tremendous. And I couldn't be thankful enough to have that opportunity as a physician. And really, a lot of it, again, I have to attribute to Stony Brook creating an environment that's conducive to supporting all of this and allowing me as a physician to participate in all of these innovations.
Well, it's wonderful to have that note of gratitude, but believe me, the gratitude is returned. The university is proud to have you, and we're very, very proud of the work that you and your entire team are doing. Dr. David Fiorella of Stony Brook Medicine, it's great to have you, and congratulations on a most successful program, changing lives and saving lives.
Thank you so much.
Thank you very much.